I'm really excited to have the opportunity to talk about some of the novel state and federal policy responses that have come about in response to the COVID-19 pandemic, because there are a number of them that impact nursing, and many of them are decreasing these barriers that states and the feds have imposed on helping and permitting nurses and nurse practitioners to work to their full extent of their scope of practice. I started a Twitter thread at the beginning of the pandemic, kind of following some of the evolving policy that's been deployed in response to COVID-19 that directly impacts nursing. And I've been trying to add to that daily. Sometimes it's multiple times a day, because policy is certainly evolving very quickly, and likely by the end of this talk, there are going to be changes to things that I've discussed. I also want to let you all know that you are welcome to type questions in the chat box or interrupt me while I'm talking. I really like having conversations and getting to know what you think about what I'm saying. So feel free to interrupt me. All right. And I just really wanted to point out that any crisis, including crises like the coronavirus pandemic, really reveal these underlying problems with our policy and regulatory frameworks. So we have seen policy evolving locally, nationally, internationally, that really hints at some of these underlying fragility of policy and how it needs to adapt to the situation. Okay. So the purpose of this presentation is to really present an overview of nursing relevant state and federal policy that's been designed to help surge the healthcare workforce in response to the COVID-19 pandemic. And I kind of want to make an argument that some of these policies, if maintained beyond the pandemic, are quite relevant to increasing access to care for many populations. So another argument that I want to make is that the COVID-19 crisis makes the basic principle of having all personnel working at the top of their education and license especially urgent. This is urgent as a way to enhance efficiency, increase access to care to populations who urgently need it, and also to reduce frustrations among healthcare team members to make teams operate more efficiently. And I think there are a couple of people on our call who can probably speak to this at a much more expert level than I can, but I'll try. Okay. So one big motivating issue that we have seen is this underlying kind of like lack of supply for the healthcare surge. The surge that may be seen in coronavirus patients. This has been witnessed in New York with almost like an inadequate supply of healthcare providers at almost baseline levels, but particularly in response to the surge in admissions to particular locations in the hospital, like the critical care units. So experts have been tracking and predicting supply problems, and we have almost targeted like some hotspots where there may not be sufficient critical care nurse or respiratory therapist supply. And some recent analyses have really raised concerns about whether the US has, one, sufficient hospital capacity, do we have enough beds, but then two, do we have enough staff to staff those beds? Because even if we increase the number of ICU beds, we don't necessarily have the staff to care for patients in those beds. So there have been some calls and some ideas about how to ensure a sufficient supply. Today we're going to focus specifically on nurses to handle that surge of coronavirus patients. So thinking about some of those policies to really close that gap. And today, because we're all nurses, I wanted to focus on that like 4 million strong RN workforce, and think about those who are employed in both hospitals and the community. So these policy adaptations that ensure sufficient providers at the bedside, but also for those more chronic conditions that are still manifesting in the community, and we still need to maintain sufficient services for. So opening up to you all, what are some recent policy approaches that you've seen to increase the health workforce capacity? What have you heard about? What have you witnessed on your units? You can chat or chime in.
Hayley, it's Laura, and I know as part of the CARES Act that was passed, the funding for Title VIII, which is the government program that supports nursing education, passed through as a part of the CARES Act, and that was considered a significant achievement and not something that we try to advocate for annually for nurses, and some years it passes through easier, but I thought it was very interesting that it went through as a part of the CARES Act.
Mm-hmm. What does that mean for nurses, for nursing students, for floor nurses, for advanced practice providers?
Additional funding for nursing education through grants for tuition as well as faculty development as well.
Has anyone else seen or heard of other policy approaches? In Texas, they're allowing retired and non-active nurses to reactivate their license without any CEU approved competency requirements. Right? They're doing that in a couple of other states as well. I don't know about the not requiring CEU or competency requirements, though. Has anyone else seen anything interesting? So some other examples include, got one more chat. Some temporary expansion of scope of practice for nurses. Great, exactly, yeah, and we're gonna be zooming into that more today. So some kind of like hospital level policies that we've probably seen are cancellation of elective procedures. So allowing for increased staffing and on COVID units, and also reduced exposure to coronavirus within the acute care setting. Health profession students, early graduation, expedited certification and licensure. At Pitt, we got all of our grades in quite early to allow for the nurses to graduate early. We have seen medical schools graduating medical students early, and also some changes to what medical students can do without going through residency beforehand. Recruiting retirees and inactive providers, activating those inactive licenses, recruiting volunteers, expanding out-of-state licensure there. So some states, including New York, have actually Governor Cuomo has done a very strong job of recruiting nurses from outside of the state and not requiring them to have a New York State license. Expansion of nurse compact licensure. Great example, Teresa, and I think what you're referring to is the NCSBNs, the National Council for State Boards of Nursing, member states. So these are states that recognized out-of-state licenses to practice within the states. So once again, expanding those, the ability of nurses and other healthcare providers without state licenses to practice in other states. Telehealth provision, a very big change that we have seen almost like on the federal level. CMS has changed some the ability of some providers and some locations for telehealth provision, including there have been some limitations in the past on needing a video almost for telehealth provision. Now it can just be done through phone. So keeping patients, once again, out of those acute surge settings and keeping them in their homes. And then last but certainly not least, what I really want to talk about today is expanded scope of practice. So why do you all think a lot of states are targeting scope of practice? Why is scope of practice such a almost like low-hanging fruit solution to addressing need for surge capacity? Any thoughts here? Especially for those of you who have long advocated for expanded scope of practice in your state.
I guess I have an example of where this would be helpful, and it's really low-lying. So for nurse practitioners specifically, and I don't think this has changed in the past 2 years since I was actively advocating, but something as simple as prescribing or writing a script for a bedside commode would have to be something that had a co-signature from a physician. And so if we need to be discharging patients out of the hospital, nurse practitioners rather, and there's this limitation for getting durable medical equipment to patients in the home environment, that could be really limiting in terms of time when you need beds because you have the ED full of COVID patients. So that's one example that comes to mind that we never could wrap our brains around.
Yeah, it's funny. I've actually kind of been sitting at the table at CMS when the DME question comes up, and it's
like obvious.
Yeah.
So and what I don't know is what are those barriers that we might not be privy to, or maybe we're not thinking about all of the details or variables that may be influencing that decision.
So
it seems pretty obvious on the surface.
Yeah, it should be pretty obvious. Like restrictive scope of practice policies do not necessarily protect patients. We're not protecting patients by regulating the ability of nurse practitioners to write scripts for bedside commodes or other durable medical equipment. We've seen that broadening scope of practice does not decrease quality. In fact, restricted scope of practice is associated with decreased access to care for a multitude of conditions for some of our most vulnerable patients with, for example, opioid use disorder. We've seen states with more restricted scope of practice have obviously fewer waivered nurse practitioners to prescribe much needed medication-assisted treatment. We've seen that full scope of practice regulation is actually associated with a greater supply of nurse practitioners in particularly high need health professional shortage area communities. And we know that even during a pandemic, comorbid chronic health conditions are not going to disappear, and patients are still going to need access to care and access to treatment for their conditions. But as many of you know who worked in advocating for expanded scope of practice, there is a very large lobby against expanded scope of practice, probably tightly tied to state and maybe national medical associations and sometimes hospital associations. And some people even argue nurse practitioners aren't going to expand access to care because they're only going to care for people in vulnerable communities, which are very frustrating, almost empty arguments. But expanding scope of practice can really increase access to care for some of the most hard-hit communities. And so I wanted to spend the next little bit about actually talking about some scope of practice laws thinking about how they're made, how they're typically modified, thinking about some baseline variation across the country, and then hone in on what expanded scope of practice looks like during the current pandemic, and take a deep dive into 3 states, Indiana, New York, and Pennsylvania. So state scope of practice laws are generally made by state legislatures, and they are implemented by state licensing boards. So for example, in Pennsylvania, there has been almost every year, a new bill goes to Harrisburg to try to expand scope of practice for nurse practitioners, and it kind of sits in committee and waits for generally the course of the year just to be recycled again. And this is for a number of reasons, including some state representatives who may have specific interests that encourage them to not advance the state scope of practice law. State scope of practice laws dictate who's allowed to work and fulfill certain roles, so who's allowed to order that DME, what tasks they're allowed to do, and under what circumstances. So often in state scope of practice, we talk about the extent to which an advanced practice provider, for example, an NP, CNS, can practice independent of a physician collaborator. Kind of that physician collaborator is key to a lot of state scope of practice restrictions on nurse practitioners and other advanced practice providers. Now, there is significant baseline scope of practice variation. This is just a very simplified illustration of what scope of practice for nurse practitioners looks like across the United States. And we still see significant different flavors of scope of practice, even within those reduced practice states compared to those restricted practice states. Something else that we've seen when it comes to changing scope of practice and modifying it is the principle of incrementalism that kind of applies across health policy. So it's not often that you go from that completely restricted to full, but there are almost incremental increases in expansion of scope of practice. And one example that I wanted to illustrate, which we'll be taking a deeper dive into, is New York's Nurse Practitioner Modernization Act. In 2014, New York went from a very restricted scope of practice to reduced, so not yet full, but allowing nurse practitioners who'd achieved about 3,600 hours of experience to practice without a written practice agreement with a supervising physician. So to practice without that physician collaborator once they had so much training. And 3,600 hours is still a lot of hours. That's years of training with a physician collaborator before nurse practitioners can practice independently. But this policy change happened after years of work by the New York State Nurse Practitioner Association. So just baseline, those 3 states that I wanted to take a deeper dive into, I wanted to dive into these states a little bit more because they do have, these were 3 of the first states to really almost jump on that scope of practice change bandwagon and issue executive orders modifying and expanding scope of practice. So baseline, they had some variation in nurse practitioner scope of practice. This is just looking at nurse practitioners. All 3 states required somewhat of a collaborative agreement with a physician for those NPs that hadn't necessarily reached those full hours to grant independence. In Indiana, NPs not recognized as PCPs, whereas they are in New York and Pennsylvania. And then in all 3 states, they can prescribe drugs. In New York, they can prescribe devices if they are in that collaborative agreement with the physician. So overall, thinking about what's being changed in some of these state scopes of practice, we have seen changes in reducing these caps on the number of NPs that a physician can collaborate with or supervise. We've seen changes in the requirement for pre-written collaboration agreements with all those procedures in place and prescriptions in place. And we've seen changes in hospital admitting privileges for nurse practitioners and certified nurse midwives. Now, as of last night, 22 states had made modifications to their state scope of practice. So these are the states that were not formerly full, but granted increased or less restrictive practice to nurse practitioners. And we still have a number of states that have not taken action on the issue or have taken such minute changes that they're not necessarily flagged in this latest American Association of Nurse Practitioner map. So I wanted to highlight this executive order that Governor Wolf issued at the end of March, which suspended the requirement for a collaborative agreement for engaging in the practice of midwifery. And he issued another executive order that allowed CRNPs to prescribe drugs outside of that established formulary, so outside of that also collaborative agreement. And I kind of wanted to get some feedback here about any NPs who may be on the call or APPs who may be on the call about what this executive order means for you and your peers, or just any opinions on this change to scope of practice in Pennsylvania. Has anyone seen this impact their practice, their peers?
Hayley, it's Stephanie. I would just hope that our Pennsylvania State Board of Nursing and advocates that are advocating for a long-term expanded scope of practice are watching this and making sure that we have the adequate evidence to show that during this period, outcomes were hopefully better, or whatever evidence we need to squash the concerns from the Medical Association and the Hospital Association, that this is the opportunity to ride the wave and make the argument stronger than ever that it's safe and equitable to expand the scope for advanced practice providers. Mm-hmm. So I don't know, do you know if there are watchdogs that are going to capitalize on this opportunity?
So I think that it is the responsibility of health outcomes, nurse workforce researchers to act really quickly with evidence that is forthcoming to examine the relationship between the expanded scope of practice and patient outcomes. Mm-hmm. And it can be challenging to do that because we don't always get data as quickly as we need it. But there are some things that I think we can be doing, we can be anticipating. So my last slide kind of has a list of asks for everyone on the call, including harnessing anecdotes, harnessing qualitative examples of how this is impacting practice, but really anticipating what kind of data needs we will have in order to demonstrate an association between mm-hmm. outcomes and practice. Thanks for asking that. Okay.
Hey, I had a teacher or a professor when I was in nurse practitioner school who always said there's an equation of the responsibility of nurse practitioners is in direct proportion to the number of people in the waiting room. And this has been so true in so many ways, that, all of a sudden the rules are, oh, well, we can change them because we have all this dire need. Um, it's very interesting, and it sort of increases the cynicism about why this, why these laws can't be changed. It will be difficult to collect data or evidence around this emergency, and because we're not sure what the outcomes really would be, and what's the actual sort of state of the art practice. These things are not defined, but just the fact that it can be done, and I'm sure done seamlessly, maybe is the evidence that we could use.
So I think we can be collecting some data on outcomes. I am particularly alarmed that we've seen decreased primary care visits, primary care consultations, chronic care management. People still have diabetes. People still have chronic conditions in the community. People are still getting urinary tract infections. And with this expanded scope of practice, nurse practitioners can be managing these conditions in the community. But where are the patients? They're not necessarily going in for primary care right now. So it will be interesting, and it's alarming. So also at the really some of the first responding states, of course, New York, Governor Cuomo issued this executive order to temporarily suspend and modify law to permit advanced practice or nurse anesthetists to practice without the supervision of qualified physicians. And then also for nurses to order the collection of throat and nasopharyngeal swab specimens for diagnosing patients with COVID-19, a regulation that this scope of practice was not permitted prior to this executive order. In Indiana, APRNs can provide services in multiple locations under a single written collaborative agreement before they are restricted in the number of locations where they could provide services. So once again, expanding scope of practice, expanding access to care. Okay. And then here is where I really make that pitch for it's really essential to be I guess kind of resilient and malleable in the outcomes that we are evaluating, and to think about a number of outcomes that can be impacted by scope of practice change. So we need research that looks at the results of the implementation of scope of practice modifications, and also understand that just because a state or federal law enables expanded scope of practice, understand that organizations, healthcare delivery systems are not necessarily going to follow those expanded scope of practice and may just continue business as usual because that's what's easier administratively, even though it may lead to decreased access to care and decrease that surge capacity. So I also wanted to highlight some really interesting, or I guess really adaptive responses from the federal government. Laura already mentioned the CARES Act and the changes to Title VIII for funding education. But we need to remember that federal government response works in tandem with state policy. When the federal government turns one switch on for expanded scope of practice, doesn't necessarily mean all states will. States can institute their own changes, and as we saw in that scope of practice variation map, not all states are turning on the ability to bring all advanced practice providers or all nurses to the front lines. And another important thing about the federal government response is that it dictates reimbursement. So we've needed the federal government to turn some things on to actually get all providers paid for the services that they're rendering. And something that you may hear about is these 1135 waivers, which states can apply for. They're kind of like this almost blanket increased provision of services that can be instituted when the president declares a disaster or emergency and the HHS secretary, so Alex Azar, declares a public health emergency. And these kind of make it easier for states to expand a number of services with one application or waiver to the federal government. And once again, kind of focusing on CMS, Centers for Medicare and Medicaid Services, and Department of Health and Human Services. Why thinking about the federal government? Because they dictate what a qualified provider is or who a qualified provider is, the services that those providers can be paid for, who can provide those services, and the places where those services can be provided. So just getting into the kind of nitty-gritty of policy, a lot needs to be in place in order for a policy to kind of stick or actually percolate down to the people who need services. So CMS implemented a number of provisions to expand scope of practice, and I just listed several of them on these on the following slides. So waiving certified registered nurse anesthetist physician supervision, waiving minimum personnel qualifications for certified nurse specialists, and then particularly honing in on these settings where they were anticipating potential surges, permitting critical access hospitals to use nurse practitioners to the full extent of their license. And then really interesting in rural health centers, changing this requirement that physicians need to direct the clinic. So really allowing nurse practitioners and other advanced practice providers to have a greater role in rural health centers. I think it would be really interesting to see how rural health centers and critical access hospitals have really used these enhanced scopes of practice to bring their hospitals and their settings to surge capacity. All right. CMS has also relaxed some rules that are helping to keep patients home. So helping to encourage the delivery of healthcare within the home and in-home health agencies, waiving the requirement for an in-person physician visit and allowing for delegates to perform those visits, or even eliminating the in-person visit overall and expanding telehealth opportunities. So with telehealth removing site limitations, in some cases, telehealth had to be performed in a certified clinic. So the patient had to travel to a setting where telehealth could be reimbursed for. Also expanding the number of eligible services that could be reimbursed through telehealth. Expanding eligible providers, allowing federally qualified or like community health centers and rural health centers to provide telehealth. Like I mentioned earlier, expanding the modality. So it's not just video, but also just telephone would be sufficient. And then really helping with the challenges in nursing homes, reimbursing for telehealth treatment in nursing homes. And something that's been key and really kept telehealth from accelerating in some settings is that requirement that we discussed before about needing to be licensed in the state where services are provided. Well, for telehealth, CMS waived the requirement for individuals to be licensed in the patient state, which is particularly helpful. So here are some of the key questions that I think we should leave thinking about and moving forward with more research, practice, action. All of these executive orders issued by the governors are temporary. How long is temporary? That's a question that we probably wake up every day asking ourselves about how much longer. Are we going to be physically isolating, et cetera, et cetera? Let's think about the implications of what are the implications of rescinding these temporary restrictions for access to care? If when temporary ends and we turn that switch off, what does that mean for providers, for patients, for healthcare organizations? And then what are these lived experiences of organizations, of teams, and of individuals in expanded scope of practice? And really, what are the implications for these groups that have long advocated for lifting scope of practice restrictions?